Hi, my name is Pamela. I'm going to present weekly grand rounds from today. And as you know, we have been doing more corneal transplant. So I wanted to talk a little bit about that. And this is what we did this April in cornea. So there were 6 different cases that we performed this April. Number one, it was a feminine 76 years old patient. The procedure, it was a DSEC. The cause was a decompensated cornea after 6 years of cataract surgery. The second case that we did, it was a male, uh, 57 years old. The procedure was a DSEC. The cause was a decompensated cornea after an SSES from last December. The third patient was a masculine 26-year-old. The procedure was a PK and the cause was a corneal hydrop. So you can see the pre and post-op picture of the patient. The fourth case, it was a male, 42 years old. The procedure was a PK. The cause was a patch and graft after a perforated ulcer in July from last year. The fifth case was a feminine, 57-year-old. The procedure was a PK. The cause was a failed DSEC from Fuchs dystrophy from January. The sixth case was a feminine, 49 years old, female. Procedure, it was also a PK, and the cause, it was a tectonic PKP for a perforated ulcer. So what's the next step, or what do we should be aware when we're working with this patient? Because we already did the transplant, but now we need to follow them. So I wanted to talk a little bit about post-op management of corneal transplant, and because there's a lot of different ways, and surgeons probably work in different ways too. So I wanted to talk a little bit about that. How we define success, it's a clear graph at 5 years. Usually it's a rate of 95% of low, when there's a low risk cases. Success, usually it's because, or it's due to corneal avascularity and also the immunologic privilege that the cornea has. During the first 24 hours, what we need to be aware of is the maintenance of wound integrity, the prevention of infection, the control of the IOP, and the patient comfort. So it's important after we're done with the case to use subconjunctival steroid and antibiotics, also the use of patch and shield, and some topical antibiotics to prevent wound contamination. Usually we use broad spectrum and low toxicity antibiotics. We use moxifloxacin in the hospital. It's important also to use prophylactic glaucoma medication, especially if the patient has a combined case like cataract and cornea surgery. Also, if we did vitrectomy or we use a large amount of viscoelastic or the patient already has a history of glaucoma. Oral steroids can be used in high-risk cases and especially antiviral prophylaxis if we already know the patient has a previous known herpetic infection. During the first to 7 days, we need to reestablish corneal epithelium, control inflammation, prevent infection, and also start treating operative complications. So it's very important to treat eyelid disease and dry eye. We can use ointments, and in complicated cases, even the use of amniotic membrane or tarsorrhaphy can be used. Also, we need to stain with fluorescein to evaluate corneal epithelium and if there's any leakage. IOP measurements are very important because we need to, they're usually associated with long-term edema or delayed rehabilitation. Also, it's important to look for pupillary block that we can treat with mydriasis and laser iridotomies. If there's surgical wound leak, we're gonna see a shallow anterior chamber, low intraocular pressure, and also a sidal test positive. And we can treat that with suture adjustment or pressure patching. Also, topical steroids are very important, a minimum of 4 times daily, the use of broad spectrum antibiotics. And when we have unusual appearance of epithelial defect, we should always suspect of herpes simplex virus, even if the patient has no had previous history of this disease. From the week 1 to the 12 weeks, also we need to prevent for infection, prevention of cystoid macular edema, any findings of early graft rejection, especially when we see subepithelial infiltrate or cutarous line. And in absence of complication, we should be slowly reducing steroids. After the first 3 months, we need to start with visual rehabilitation, management of long-term complication, and avoidance of iatrogenic problems. This would be like the if we don't follow for IOP and the patient is using a lot of steroids, that not treating on time the pressure, or also if the patient develops cataract for the use of steroids or things like that. So when we talk about corneal graft rejection, we need to be aware of the donor factors or the host factors. So the donor factors, we know that there's a major histocompatibility complex, and we can be doing like matching or compatibilities. ABO compatibility also too, and like the procedure, the way the eye bank preserve the tissue, or preservation time to death, or the storage media they use. We don't do routinely. The major is the compatibility. We don't do it routinely, or the ABO compatibility. Also, host factors, maybe they are the more important ones, like primary diagnosis, the recipient age, the sex of the patient, if the patient has history of previous transplant or rejections, also corneal neovascularization when there's more than 2 hours, and if the patient has
from the gym.
glaucoma previously.
From the office to the gym.
Also, the surgery related factors, when there's a graft size that it's more than 8 millimeters, or the lens status, or if the patient has an anterior vitrectomy. And the post-operative factors like suture related problems or the formation of anterior synechia. We need to identify the type of rejection, if it's epithelial, chronic, or stromal, or subepithelial, stromar, or endothelial. The most common and the most serious form of this is the endothelial. Then it has a characteristic of the cutarous line, the AC chamber cells reaction, and also corneal edema. But we need to be aware of the other ones so we can recognize it. Like the epithelial one, usually there's an epithelial rejection line. It usually stains, and it can present also as a leukocytic infiltration. And usually these sites are more quiet and can be sometimes asymptomatic. The subepithelial infiltrates can mimic an adenoviral keratoconjunctivitis, and usually they disappear with topical corticosteroids. And the stromal one is usually see when we do lamellar keratoplasty, and they're isolated peripheral stromal infiltrates. So for prophylaxis, usually the regimen employed and the prevention of rejection depends on the surgeon, the geographic location, and the risk category of the transplant. I found this image very interesting because when we're talking about preventive therapy, we need to target these basic pathophysiological processes. And the first one, that is the hematoangiogenic privilege. So it's important do we do reduction of the corneal neovascularization, and there's different ways of doing it, like laser photocoagulation, fine needle diathermy, anti-VEGF, that it's what we're using currently in the hospital, and also the use of topical steroids. Talking a little bit about the immune tolerance, the role in immunosuppression, it's very important. We can use topical drugs like corticosteroids, also topical cyclosporine or tacrolimus, or systemic therapy. Tissue matching, like I was telling you, it's not a universal practice, and we don't do it. And there's some like new approaches for immunomodulation, like gene therapy. They're using virus as a transfer vehicles to prevent the corneal rejection. Also for antigen modulation, they're using interleukin 10 and transforming growth factor to alter the antigen presenting cells, and also the use of anti-VEGF and monoclonal antibodies. They're, as far as I know, they have been just using this in animals. So the proposed post-operative protocol, usually it's using steroids like prednisolone acetate, 1% 4 times daily for 1 month, then 3 times daily for 1 month, then 2 times daily for 1 month, and then 1 time daily indefinitely. The studies they haven't shown advantage using systemic steroids. The use of cyclosporine, its efficacy, it's debatable, and especially in high risk patient, it's not recommended. So when they perform a study, and they were like comparing the use of dexamethasone alone compared to dexamethasone more adding cyclosporine, and there was no better than so there was no significant between the two groups. And the group of tacrolimus, and the group, they were using like tacrolimus like as an adjuvant group. They had a lower rate of irreversible graft rejection than the prednisolone alone group. And they're using now the fluprinate, that I think the brand is Duracell, and it's expanding a little bit more to control edema after surgery. So this was the proposed chart they use, or the proposed protocol they were using. The two important ones to mention here, maybe they're DSEC and PK, that it's what we're working with. And they were suggesting with DSEC using prednisolone 1% and gradually taper for 1 year, and then switching to lateranol or fluorometrolone 1% once a day indefinitely if it was a low risk. If they have an episode of rejection, so the things changes a little bit, or if the patient had a glaucoma induced, they were switching to lateranol. And for PKs, they were comparing low risk and high risk. For low risk, they were using, yeah, again, prednisolone 1% every 3 hours and gradually taper for 1 year, and then prednisolone 1% once a daily indefinitely. And if they were high risk, they will be using subconjunctival bevacizumab or Avastin, and prednisolone then gradually taper for 1 year, and then they can be using like prednisolone and tacrolimus at the same time, twice a day indefinitely. But if they had an episode of rejection, so they bump the steroids until every hour drop, and also 1 milligram kilogram or systemic, and they were gradually tapered when the episode was resolved. And it can be used subconjunctival dexamethasone or triamcinolone alone. And if the rejection do not reverse, they decide it was a graft failure. If they were able to reverse it, then it was a high risk and they came back to the one prednisolone 1% daily indefinitely. So, because we are working too with DSEC patients, the risk of graft failure is lower compared to PK, and the factors that can affect that it's because there's a lower antigenic load, there is absence of sutures, and also there's a lack of exposure of the graft to immune mediators, and the clinical presentation for the rejection of this patient can be asymptomatic or can be with pain, redness, photophobia, watering, isolated KPs, corneal edema, or anterior chamber cell reaction. So, following EK offers a challenge in early diagnosis, and it's important to do a careful slit lamp examination and pachymetry. That it's something that we're not doing routinely right now, but I added in my recommendation at the end of the presentation. And another thing that I want to add it here is the management of astigmatism, because it's important. Usually, so the cases that we usually do, it's not, so our individual sutures, no running sutures. So sutures should be kept for at least 1 year. If the astigmatism is more than 4 diopters, can be reduced by suture manipulation. Usually what we will be doing is a selective interrupter suture removal, and that we will be doing that if we do topography, so we know which suture should we be removing. So the successful in visual rehabilitation depends partially on accurate identification of the tight interrupted sutures. Topography has the advantage of mapping subtle corneal power changes and accurately over the entire optical zone. And this we use it for identification of the steep meridians that can be attributed to specific sutures. In the interrupted suturing technique, selective suture removal can start as early as 2 months after PK. There was another article that they were mentioning as early as 4 months, not before that. So I think we can discuss after when should we removing the suture, or how early can be removing the sutures, because we need to remove the sutures in the steep axis. And after initial suture removal, non-adjacent suture can be removed at an interval of 4 to 6 weeks. And when a small amount of astigmatism is achieved through suture manipulation, the sutures are left in as long as possible until they fray or break. And if we are not able to manage the astigmatism by removing sutures, we also know that we can do contact lenses. We can send the patient for contact lens fitting, or there are other procedures that we can do, like keratotomies, or we can do like the last option we would be like repeating the transplant, or there's another option that it's the wedge of the, like cutting the wedge or the um part of the transplant to remove sutures. And some,
Pamela,
yeah.
Pamela, there's two other options there. If I read your slides right, you can actually add sutures back in eyes that have had all the sutures removed. With, if there's a lot of residual astigmatism, you can put a suture back in if you want to change the shape of the eye. So that's very effective. And I can't tell if I saw or not, but you can do you can do PRK over the surface of a transplant. Maybe that was on there. I maybe I didn't see it, but there's you have some other options there.
Okay. And some take-home points were to evaluate risk factors previous to surgery, decide the best procedure according to the patient pathology. It's important to follow IOP carefully. We need to do topography follow-up every visit for PKs and pachymetry follow-up in these patients. And these are my references.
Thank you, Pamela. That's a great overview of what goes through your mind or a mind as you're managing a corneal case. Seema, you were involved with a lot of those. Do you want to add any commentary about the types of patients that you encountered specifically on your last visit? And I'm also interested with you had some DSEC and some PK tissues. I'm interested to see what your observations are now about the ability to do those at La Familia Eye Center.
Absolutely. Pame, that was an excellent summary. This was a talk I was hoping to have with the people there while I was there, but we never had the time to do it. So thank you. We continue to have more patients that are suitable for PK than EK right now. And I think most of that is because of the advanced pathology that presents, and most of their corneal scarring is from perforated corneal ulcers that arrive too late to be treated prior to perforating. So I think their skill set still, until we can get to a more preventive phase of care, is going to be, in doing PKPs and managing them well. So doing them, I think they're all just fine. I think the management is where we need to focus our energies going forward. And with the addition of an optometrist there that's going to help with contact lens fittings, with opticians willing to make contact lenses, I think that will take off, which will be great. They are certainly at a level of being competent doing EKs. Claudia is great. Pame did a couple with me. And so, again, I think just managing the post-op management and recognizing the complications and how to manage those post-operatively will be important going forward. But my summary is there's still a need for management, post-op management of PK more than DSEC for right now. And we're not quite at the level of DMEC, I think, because of post-op follow-up of patients. So
Seema, I have
That's
a question
great.
for you guys. Seema, you and I talked about this in January when we were there. If it's a herpetic PK, there's inconsistency, I think, with acyclovir post-op, and for how long do you use it? So what do you think is the appropriate course of acyclovir, oral acyclovir use in the post-operative care of these patients?
So for me personally, I keep my herpetic patients on prophylactic oral acyclovir for the rest of their days, partly because I'm also going to be keeping them on a drop of steroid a day. They're high risk to begin with, and they remain high risk after their PK. So for me, the two go hand in hand. Prophylactic oral acyclovir and steroid.
What dosage, Seema, do you use?
So depending on what their etiology was, if it was just anterior herpetic eye disease, then you can use 500 milligrams of acyclovir once a day. If it was endothelial involvement, then I go with a gram of acyclovir a day. And sometimes you have to use more than that and kind of tailor it based on how the patient is responding. So, you know, they can recur despite that basic prophylactic dose, and some of them end up needing more.
And
As
Pamela,
long
is that
as
what
you're
you guys are
checking
doing?
their renal function, it should be safe practice to do.
Okay. And Pamela, is that what you guys are doing now with acyclovir, or do you have a different regimen?
It's the same.
I think Pamela said the same thing. The only thing I would add to that is, I think a patient coming in with a corneal scar that has that you've concluded the cause to be herpetic eye disease, and the other eye is functional, I think I would run as far and as fast from that case as I could, in terms of whether that's a good case for transplant, especially in Guatemala, but even in the States, I'm just really hesitant to do those cases because they have such a poor outcome. And there's nothing worse than herpetic eye disease and the scar than a failed corneal transplant and herpetic eye disease and a scar and a neovascular cornea. So I guess seeing that, I'll just throw that out there as a guideline to this. I think a common presentation by a resident of what looks like a great transplant case, but when you get down to what the expected outcome is, it's just so poor that I think it turns out that's a really bad case. I'm wondering, do other people have that same bias or that same hesitancy with those cases? What's a scenario where you would feel comfortable doing a transplant on a patient with a scar and either zoster or herpes shingles, herpes simplex as a diagnosis?
I'm completely with you on that, Andy. That's a great point, and that's how I manage my patients. I do run a mile from doing or recommending corneal transplants in herpetic eye disease patients, as long as their other eye sees fine. I think the majority of cases that we see in Nuevo Progreso are trauma. It's fungal ulcers that have needed patch grafts that are horribly vascularized, and their high-risk status comes from the neovascularization. But these are often very young patients and desperate to have improvement, and several of the patients we've done have had bilateral pathology, and so we're kind of obliged to try something on one eye. And something we did more this time, because we had Avastin more readily available, was to give them subconjunctival anti-VEGF at the time of surgery. And I don't know how they're looking now, a month out, but the first week after surgery, they looked amazing.
I just want to comment on corneal scars in general, and maybe Rupert can comment on this too. A lot of times these patients with corneal scars, whether herpetic or traumatic, do great with a contact lens. And sometimes the level of opacity can be deceiving. And really it's the irregularity of the cornea, not the opacity of the cornea, that's causing bad vision. Sure, there's exceptions to that, obviously severe scars, but I'm always surprised at patients who have a big traumatic scar or a herpetic scar, and you fit them with a scleral lens and they see 20/30 and do really well. So that would be my thought on that. But I also had another comment on the follow-up, which I think is really important. I don't think anybody's brought this up yet. Increased IOP following PK is commonly thought to be steroid related. And sure, it may be, often it is, but what I see in these high-risk cases that are a PK after a fungal ulcer or another high-risk type of case, a lot of times you've got creeping PAS. And this is a very important thing for any PK surgeon to be attuned to, because if it's caught early, you can save this patient a world of headache and needing to get a glaucoma drainage device, et cetera, if you can reduce the PAS early and do a pupilloplasty of some kind, either a cerclage. It's not enough just to go in and peel the iris out of the angle, because it'll stick right back. But if you mechanically hold it out of the angle by doing a cerclage, or like put a couple sutures in to sort of pinch the pupil together, that is pulling the iris down and away from the angle, a lot of times you can prevent chronic angle closure glaucoma in these patients. But anyway, I've just noticed a lot of times I'll get patients referred to me for steroid-induced glaucoma after PK, but they actually have chronic angle closure glaucoma.
That's interesting, Eric. So are those those aren't in just kind of straight up PKs for Fuchs, but these are in
right. This isn't
size.
your high drops case, your severe keratoconus.
Yeah.
These are the post-fungal ulcer. These are eyes that had a lot of inflammation before. In fact, we saw earlier in the clinic today, we saw that patient with a PK, and I had put an Ahmed valve. The tube is in the sulcus because the iris is just completely stuck up to the graft-host interface. But usually you can catch that early on if the surgeon is attuned to it and sort of watching for it. What seems, because the timetable can often be about what you expect with steroid-induced glaucoma. So you think, oh gosh, you're getting steroid-induced glaucoma. Now I got to switch to loteprednol. And then you get yourself in a vicious cycle when really they don't have steroid-induced glaucoma. They have an anatomic change that's causing the increased eye pressure.
So, Eric, how successful have you been with doing pupilloplasties in this patient? Because I dealt with one just last week who had a history of chronic inflammation. I had done a DSAC 6 years ago. She did well. The DSAC failed. She had a tube shunt. And I had to come back, and she had PAS everywhere. And my plan was to do a pupilloplasty to hold the pupil down. By the time I had gently tried to peel all of that iris off, it was shredded. There was nothing left to do a pupilloplasty with. So I think that's the challenge with these really tough cases. We did a PK like that when I was in Nuevo Progreso, and we would have done a pupilloplasty if there was anything left to cobble together, but it's just, it's
no doubt
really,
about
really
it.
challenging.
Yeah. No doubt about it. There's these cases, they had a perforation, the iris was stuck to the cornea already. Those cases, when you do the PK, they already have fixed PAS, and you're kind of, the die is cast on that. So that's a different scenario, but it is important to be aware nonetheless that if the pressure's high, you can still continue with the steroids that you need, because the steroids is not making the pressure go up. Keep them on the steroids. They're going to need some kind of a drainage system created for themselves. That's all. But yeah, it's a good point. Not all these irises are amenable to pupilloplasty. Some are already torched. They're already fried. But when they've had a PK and they started out and they were okay, and 2 or 3 months later, you see the pressure going up, that's when I'm just saying it's a good idea to consider it anyway.
Eric, any pearls on doing gonioscopy on post-PK patients?
If the corneal graft is good, you can usually still, if it's not a 6 millimeter graft, if it's a 6 millimeter graft with an opaque host, then good luck. Then you can use your anterior segment OCT or a UBM, I guess.
Okay.
But
sometimes a Goldman lens, you put some genteel gel or whatever gel you use, you can get a better view that way than with a Zeiss.
Mm-hmm. It's hard to beat the view with a
fill in the surface.
Yeah, a Volt or a Goldman 3 mirror. It's really hard to beat the view that you'll get with that. We don't use it that often because it's so quick and easy to use the tear film based lenses like the Sussman or Volk. But gosh, you just really cannot beat the view that you can get with coupled with genteel gel, like you said.
If you don't have the gel, if you're quick, if you fill it up with just some saline or tears, if you don't have if you don't have the gel, and if you're quick, you can pop it on to the eye and get it to work that way.
Yeah, well, I know where to refer those patients now, Eric. So thanks for.
I got my fill. I got my fill. Thank you.
Well, that's just one last comment. I just wanted, before I forget about it, in talking about suture removal. I was trained, as I think as a lot of corneal surgeons, to selectively remove sutures. But I will say I've had 4 early patients that we removed sutures after a year, and within a week, all 4 of these patients had graft dehiscence or wound dehiscence. And we actually ended up publishing that with Terry Kimbeck at Duke. And the insight was that a lot of the elderly, maybe Caucasian, less vascularized eyes, I'll leave sutures in just a long, long time. Some surgeons don't take any sutures out until they break. So I just would, I think, caution our young learning surgeons on PKs that you don't need to take them out during that first year, unless you feel obligated because they've broken, or there's vascularization, or they're super tight, or maybe there's some intolerable astigmatism. But rather, I would just kind of err on the side of leaving them in longer. That's be my.
I do the same. I leave them in just for graft host junction integrity, especially the elderly.
Yeah.
Because that wound never heals. So I just take out the tight ones. I aim for astigmatism of less than 3 diopters, but if I don't get it, they get a contact lens anyway. So
well,
that just reminded me, one last comment real quick.
Yep.
It just reminded me of something when you were saying that, Andy. I think for the younger surgeons, it's super important to set expectations about a corneal graft with patients, because they've had this disease, they're going to have a corneal transplant, so they think they're going to see really well next week. And just setting expectations of, oh yeah, this is going to be a real long process, I think is important.
Yeah, it's a year process. DSEC different, but yeah, those PKs are wild. Wish everyone a great week, and we'll see you next week. Have a wonderful time.
Good night, everyone.
great job, Tammy.